Hi, everyone. Thanks for tuning in and listening in. I'm really glad that you're giving part of your Saturday morning. And what we hope is this is going to be a really educational and informative seminar for you. I've known Andy McGillicuddy and Nikki for many years. We've met at many of the regenerative medicine meetings. In my experience, Andy is one of the most well-read and knowledgeable people in the field of stem cell biology. And I asked him to come and talk to us and really do a brain dump on us of all the knowledge that he's accumulated, particularly addressing a lot of the common questions and confusions and myths that people have regarding stem cells. What's the difference between bone marrow and adipose? What's a CFU? What are all these markers that people talk about, such as CD34? Do you need to filter out the spicules? Are the spicules a bad thing? And there's so much misinformation and so much confusion and so much just that's not really well understood and well communicated. And I wanted Andy to come down and try to clarify a lot of that so we're all on the same playing field regarding understanding what we're doing. So I'm going to turn it over to Andy. Thanks for your attention. For those of you who are tuned in live, you're going to be able to send in your questions, and we'll be able to address those on the fly. For those of you who could not be here live, this will also be recorded for future use. Thank you, Andy.
Thank you so much, Dr. Paul, for that great introduction. So I want to really start by saying, these are our opinions based on our background and experience. And the purpose of the discussion, obviously, is to share information and foster ideas, ultimately leading to better patient care. And, of course, all opinions and perspectives are welcome. Nobody has all the answers for sure. So these are some of the myths we want to cover today. One is regarding red cells, and there was a paper that people often cite that's saying red cells are not helpful for tissue regeneration. So we want to dig into that perspective a little bit. And then how and where you aspirate within the iliac crest. Where are stem cell niches and how do different aspiration techniques target those niches? Whether you want to filter marrow or not, and what is a marrow spicule. We'll talk a little bit about centrifugation. Does it really help, or is it a necessary step? We'll talk a little bit about how your body ages and what impact that has on your marrow space, and then what clinical insights can we gain from that. And then a little bit about FDA. We've heard a lot about these new guidance, and we want to give you our perspective on what that guidance means. And then some miscellaneous different things we've heard at meetings we'd like to cover. And ultimately, we want to end with, hey, if we look at all these different topics, is there something that we can glean to change the way we treat patients and maybe make that therapy more effective? So the first topic I want to talk about is red cells. And these are the papers, especially this one, the top one, that people often cite now as, oh, red cells are harmful for tissue regeneration. So this paper that people are citing was done by Professor Zaire and Stephanie Daimler. I've known them for years. And it was an acute MI, acute myocardial infarction model, where they were delivering marrow over a balloon over the coronary artery after someone suffered a heart attack. So they were delivering this marrow systemically. And this second paper was the second site that was meant to show, hey, we're going to do these two studies in parallel to show that we can get the same results at multiple centers. And then this is a third paper that did a similar model, but concentrated and delivered the cells a different way. So first thing is I want to talk a little bit about is the physics of centrifuging marrow, because all of these papers centrifuge the marrow. So when you centrifuge blood or marrow, your red blood cells sediment 35 times about that faster than a platelet. And the reason for that is red cells are denser. They also have an electrical charge, so they stack up like coins, and that's called reloading. So your red cells sink very rapidly. Your white cells, which are more dense than platelets, also sink rapidly, about 12 times as fast as a platelet. The platelets, because they have a density of like 1.03 and plasma is about 1.01, the platelets actually start to rise initially during the centrifugation and get captured in the plasma. That plasma is referred to as a blood banker, as platelet-rich plasma, and they use that for transfusion. And the reason they do that protocol is they don't want white cells, because white cells have an immune profile. They just want the platelets in the plasma. Then if I do a secondary step and I take that plasma that has the platelets in it and I centrifuge it, I create what the blood banker refers to as a platelet concentrate. In our world, it's often referred to as pure PRP or clear PRP. And then what was referred to in musculoskeletal as PRP would make no sense to a blood banker because it has, the white cells and the red cells in it. So I want you to think about that, though. When you make pure PRP, you aren't getting any real number of white cells or stem cells because the stem cells have a density that overlap with the density of young red cells. There's no way with simple centrifugation to get a lot of stem cells without some red cells. All right, so now we're into this first paper. I take the marrow out for these patients and I process it, but the processing I'm using is an old technique of using a FICO gradient. And so it takes me 24 hours from the time I take it out of the patient to put it into the patient. And the way I process that marrow isn't using AABB standards, so it's sitting in a static environment for 24 hours before it goes in. And when I looked at the difference between treatment and control, there was a clinical difference between treatment and control. But on the treatment side, when I stratified by the amount of red cells, the patients that did the best had the fewest amount of red cells. But remember, I'm delivering them systemically. The number of red cells in my treating composition is nothing compared to the number of red cells you have systemically in your body. But the point of the paper is saying the red cells impacted the quality of the biologic. Well, it turns out that this paper now, which followed the same protocol, did not have any red cells. So they made what would be considered like a pure PRP. So by eliminating the red cells, though, they eliminated most of the stem cells. This paper had a difference between treatment and control, but they noticed it declined the more red cells in the treating composition. This one, where I eliminated the red cells, but also the stem cells, no difference between treatment and control. And then this last paper repeats this experiment, but it does it in a way where I centrifuge the marrow and put it in almost immediately. And this one, the more red cells I delivered, the better. And that's because I didn't impact the biologic by letting them sit in the presence of red cells for 24 hours. So in effect, what I see here is if I process things in a way that doesn't make sense, I'll damage the biologic and the biologic won't work. The less I do to that biologic, the better it's going to work. And in fact, red cells had no impact whatsoever when I just processed them and put them in fresh. When I look at this paper and someone says, oh, you don't want red cells. And with respect to marrow, that makes really no sense because you have to look at this paper that when I eliminated the red cells, there was no difference between treatment and control. If you want stem cells from marrow, you're going to have red cells. There is no way to eliminate them because of the density overlap. And then lastly, the less you do to the biologic, you take it out, you put it back in, you don't do a lot of manipulative steps. I personally don't feel that the red cells are going to be a problem. So the takeaway from these papers is there is no evidence that red cells are bad as a result of these three papers. And then there's some theories that, and it's backed up by some clinical work, that if I photobiomodulate the red cells are a nitric oxide sink, if they're hit with a certain frequency of light, the energy from the light causes the red cells to release the nitric oxide. And nitric oxide is actually a helpful molecule. It's a stem cell stimulant. So the idea that red cells are harmful or inflammatory, I'm not sure that I buy that argument, especially given that red cells are such a low profile kind of a cell. I mean, I can transplant red cells from one patient to another without any immune conditioning. All I need to do is match the red cell type. However, that's not true with white cells. When I transplant white cells, they have a very strong immune profile, and their job is to create inflammation. So in all likelihood, when you make a high density PRP, you wind up with a lot of white cells and neutrophils overlapping with those red cells. And there's this concept of inflammaging where the older a person gets, the inflammatory profile of their white cells picks up dramatically. So I can look at two different studies, one where the more white cells and red cells I include in my PRP, the better the result. And that's an animal model. I look at another study, the more white cells and red cells I include, the worse the result. Well, the difference is the age of the model. So if it's a young, healthy patient, maybe a high-density PRP would make sense. But if it's an older patient where they have an enhanced inflammatory profile, a pure PRP or a leukodepleted PRP probably makes sense. So it's not one size fits all. It's kind of, I have to look at, the profile of my patient and then pick which one of the two kind of makes more sense. And I think since white cell's job is to be inflammatory, and you have a flare, it's likely caused by the cells that are responsible for that, which is your white cells, which overlap with your red cells when you make a high-density PRP.
So you don't think it's the red cells causing the inflammation?
I do not think red cells. I think it's white cells, and you can't really disassociate the two, because when you use high-density PRP, you always have both. And my suspicion, it's given especially the information around inflammaging, it's the white cells. And from a practical point of view, do you really care? If I use high-density PRP, I know I'm going to get some inflammatory responses, especially in older patients. So that insight, though, can help you pick high-density or low-density based on the inflammatory profile of the patient you're dealing with. If they had high C-reactive proteins, you probably want to go with a pure PRP. If they're, really young, healthy, high-density PRP. So that's it for section 1 on red cells. Nick, do we have any questions on that?
We do. We have a few questions. The first one, if red cells are not harmful when used systemically, based on your analysis of these cardiac papers cited, isn't it still possible they are harmful when we inject them into a joint?
Yeah, so that's an interesting question in that I agree that when I look at the cardiac papers, they were all delivered systemically, so I'm putting them into the circulatory system. And when I'm using it in musculoskeletal, I'm not putting them into a circulatory system. I'm putting them into a joint where it's going to be now more static environment. However, I think that just the metabolic activity of your body allows your body to remove those red cells before they create a problem. So while there's no way of really knowing unless you were to disassociate the white cells and the red cells in some kind of a study, what I suspect is that it's the white cells more so than the red cells that are creating that inflammation.